Hi, I'm State Senator Irene Aguilar, and I want to tell you, in the past week, I've had 3 different opportunities to speak with people about healthcare, and each of them had a different objective and goal and slightly different topic, and that's my long-winded way of saying my slides don't look the same. They're all different. My apologies. But what I was asked to speak to today is the whole concept of universal health care. What is it? What isn't it? And then talk some about the effort that had happened in Colorado and what happened there. And so that's what I'm going to do for you. So in order to explain to you a little bit about a single payer system, I want to first start by telling you a little bit about a multi-payer system. And that is what we have in the United States, is a multi-payer system. So this is a schematic produced by the Kaiser Family Foundation, so not by those of us who maybe have an agenda, about how you get health care right now. And what it shows you is that if you have an employer who provides health care, you get it there. If you don't and you're low income, you get Medicaid. If you don't have an employer and you're not low income, you go on to the exchange. And these are all the different steps you go through and the different assistances that are available to you. And what this and this actually is simplified, I'm sorry to tell you. But what this leads to is what we have in Colorado today. I stole these from the Colorado Health Institute, who every 2 years puts out data on where we stand in insurance in the state of Colorado. And so what we have today is that we are down to 6.5% of our people without any insurance at all. And this compares to before the Affordable Care Act when we were at 15.8%. So you see we've made tremendous strides. Those people who do have insurance, there are a couple of remarkable things here. The first thing that I'm sure sticks out to everybody is that the number of people with Medicaid has increased dramatically. And one of the provisions of the Affordable Care Act was that the federal government would pay 100% of the cost of offering Medicaid to people whose incomes were low for the first 3 years, and eventually have the state pay 10% and the federal government pay 90%, which is much better than usual. Usual is 50-50. So we've gone from about 12.2% Medicaid in 2011 to 19.9% Medicaid. I've heard figures as high as 25% Medicaid, and that's where a lot of the reduction in uninsured has happened. But the second thing that I think is really notable is if you look at what's happened with employer-sponsored insurance. Now, the reason employers pay for insurance actually came about through World War II, when there were freezes on wages and companies wanted to find a way to still attract employees, so they started paying for benefits. And then Congress gave the companies a tax benefit for doing that. So you'll often hear people say, oh, people who get their insurance through their employer pay less than I do because they pay it without having to pay taxes on it, and that's absolutely true. So it used to be that like 75% of people got insurance through their employer. That was down to 57.7 in 2009, and now we are down to less than 50% in the state of Colorado who get their insurance in sort of the cheapest way, if you will, possible, which is through your employer before taxes are paid. So all of these different entities are paying medical bills. Now, it looks like one big block, but actually through that employer-sponsored insurance and this individual insurance number here that's up to 8.1%, that's where the exchange comes in. In each of those, there can be hundreds of different plans. And this is the effect of hundreds of different plans. It's hundreds of different prices. So we have something in our state called the Center for Improving Value in Healthcare, and they get payment data from insurers on how much they paid for different diagnostic codes to different facilities. This is how much different private insurance companies paid for a knee replacement at different hospitals across our state. So they've all billed code 5 for total knee replacement, and their reimbursement has varied from as little as $20,000 at facility A to as much as $47,500 at facility V. Again, they've all done the same thing. It could even, to be honest, in some cases be that the same doctor did the same thing in the same hospital, but 2 different insurances were billed. And so this is what a multi-payer system does. Now, part of what you don't see in here that's important to know is every single one of these rates is negotiated. So if there are 100 different kinds of private insurance, the business is negotiating 100 different prices for their private insurance. Here's the other thing that happens with a multi-payer system. There are winners and losers, and in general terms, people who have private insurance are winners because private insurance pays significantly more than government insurance. This is the difference in prices in different regions of our state between not prices and payments, between private insurance and Medicare. How many of you know someone at Medicare who had trouble finding a doctor because the doctor didn't want to take Medicare? Right, so if you're a private doctor and you could get paid $40,000 for private insurance or $23,000 for Medicare, what are you going to want to take? You're going to want to take private insurance, right? What's not on here, but would be even about lower, 20 to 30% lower, is Medicaid. And so even though we now have 20 to 25% of our population with Medicaid, Medicaid reimburses so low that there's a disincentive to seeing those patients. And so this is what multi-payer does in terms of patient access. And this is what it does in terms of the satisfaction of a provider. It burns them out, right? Because they have to figure out what insurance do you have, what does it cover, how do I need to bill that? If the bill gets rejected, is it because I did the form wrong? Is it because I did something the insurance doesn't cover? And so it just creates an administrative nightmare. And in fact, our Institute of Medicine has estimated that we waste almost a third of our healthcare spending in healthcare, and about 25% of that is that administrative nightmare. Another 27.5% of that is what's called unnecessary services, and I'll explain to you what that is. Right now, most providers in our state get paid on what we call a fee-for-service basis. That means that everything you do, you get paid for. Anything you don't do, you don't get paid for. So if you come in and see me and your blood pressure, the guidelines got changed this week, and your blood pressure is 138 over 78, I could ask you to come back in and I'll make more money off of you. If you come in to see me and your blood pressure is perfect, I don't make any more money off you because I don't have a reason to see you again. And so it incentivizes providers to do more. There's a great article by Atul Gawande called The Cost Conundrum that discusses how cardiac catheterizations are more prevalent in communities that have more cardiologists. It's like, as my husband says, asking the barber if you need a shave. The other waste here is inefficiently delivered services. Because insurers are trying to figure out what bill do I have to pay and not have to pay, they often set up these ridiculous rules. And I'll give you a story about that. My daughter is disabled and had this surgery, and she got a horrible ulcer on her Achilles tendon. And there was this really expensive cream that was prescribed to treat that ulcer. Well, the insurance wouldn't let us, as her doctor parents, my husband and I are both doctors, buy the cream and put it on. Only if a nurse came to our home could the cream be purchased for by the insurance and put on. And I'm like, really? I'm a doctor, I could do this. And they said, sorry, we only pay for it if a nurse does it. So that's inefficiently delivered services. These are rules meant to try and keep people from abusing systems, but unfortunately frequently lead to higher cost services being provided than need to be provided. And so that's what a multi-payer system is. And that's really why the United States spends so much more, and I didn't even go into profit. I'm being nice today. And that's why the United States spends so much more on healthcare than any other developed country in the world, and yet is the only country that does not guarantee access to basic healthcare to all of its residents, legal residents. And this is data from 2012. I haven't been able to find a more updated Commonwealth Fund data source, but I did see data this year that the United States is up to $3.3 trillion spent on healthcare. It's 18.6% of our GDP. So that's multi-payer healthcare. So what is universal healthcare? So universal health care is a system that provides health care and financial protection to all the citizens or legal residents of a particular country. It usually provides a specified package of benefits to everybody who lives in that country, and the end goal basically is to protect their people from financial risk, to improve their ability to access necessary health care services, and to have improved health outcomes. And I probably at this point should insert one of those slides that shows how even though we spend the most on healthcare, we're not ranked number one in terms of health outcomes. Now, that is different from a single payer system. In a single payer system, again, every legal resident is given a common benefit, and it's assuring equal access, but all payments are through a single pipe, and there's uniform payment rates and common claim processes and adjudication procedures. So you don't have 20 different rates that vary $27,000 for a knee replacement. There's one rate. Everybody gets paid that rate. You don't have 40 different forms for how you get paid. There's one form. Everybody fills out the same form. So there are different ways to get to universal coverage. One is through doing single-payer health care. Another would be through doing a regulated private health coverage system. And the third would be through using a mixture of public and private coverage. And I'll go over these details that are in the little boxes that you can't read in just a moment. So single-payer health care usually is comprehensive care with no co-payments at the point of service, because co-payments generate more paperwork and more administrative waste. Usually all legal residents are covered, and the government finances health care with taxes and pays the providers directly. Now, there are two examples of this that you're familiar with. The first is England, the United Kingdom. And in that case, the government also owns and operates the hospitals and employs the providers and pays all the bills. Another method is Medicare for all, which Canada has adopted. And in this case, the government determines the rates, pays the provider, determines how bills are paid, but the providers are in their own private practice. They're not owned or operated by the government. And this would also be Medicare, as I mentioned. This was way back in 1946 when our forefathers in England said, no society can illegitimately call itself civilized if a sick person is denied medical aid because of a lack of means. And I've heard people say, we have universal health care in the United States. You get it when you go to the emergency room. Well, let me tell you this. Way back when I was a youngin', and I'm not that old, it was true that if you came to the emergency room with anything, they would see you and take care of you and send you out. These days, they actually look at you and determine if you're really having an emergency or not. And if you are not in danger of threatening your life or livelihood, they will turn you away. I saw a patient in an urgent care center who had severe back pain, so bad that she punched out a window because she was so angry that an ER turned her away. But they wouldn't treat her because she wasn't going to die from that severe back pain. And that's the kind of health care we have in the United States. So regulated private health coverage, the example here will be the Netherlands. So the government defines what the health benefits are that fall within their purview. There may be co-payments for some services. Usually things like maternity care and children's care don't have co-payments. Everyone is required to have insurance, and people pay premiums. The insurers pay the healthcare providers, but it's done in a very regulated fashion. For example, the government basically pays the insurers what they need based on what the risk pool is of people they're seeing. So what this means is, for example, people who are over the age of 65 are more likely to be sick and have diseases that cost a lot of money. There can be people 68 who don't cost any money. So if this insurance company has most of the people who are really sick, and this insurance company, most of their people are healthy, and a classic example here would be Medicare and a Medicare Advantage plan, the Dutch government would readjust the money that was spent and give more to the group that was covering the sicker patients. And they're not for profit, and they're highly regulated to ensure that they're not inappropriately denying claims. France is an example of a country that has a mixed public and private healthcare coverage. They do have a wide range of services that are covered, but private insurance does fill in gaps. Again, all legal residents are covered. The government finances it through nonprofit funds that pay the providers, and then most people buy an additional insurance for things like glasses or dental care, which some doctors like me would argue shouldn't not be considered part of healthcare, but it's just a very different system. Again, regulated, not profit, private market. And the reason when people go to these countries and they get seen in the emergency room, they say, oh my God, I had an appendectomy in France, it was only $3,000, is because the prices are set and determined by a single negotiator who says, this is what it costs to do this, as opposed to the 60 different prices in our country. So in 2016, we did try to create a single payer system in the state of Colorado. It was known as Amendment 69. Our taglines were that we cover everyone, we save billions, and we would design it in Colorado for Coloradans. What we were going to do is operate under the Section 1332 of the Affordable Care Act, which is still out there and still exists, which allowed waivers for states to try something different as long as they covered at least as many people with at least the same level of benefit, that it did not increase costs for the people, and that it did not increase the federal deficit over the next 10 years. And so what we proposed was a single payer system where everybody kicked into the tax system. Employees would pay 3.33% of their income, and there was an upper limit cap. I'm embarrassed to say I think it was $450 for a couple, $350 for an individual, meaning $350,000. You paid 3.33% up to that level of income. And then for companies, they would pay in 6.67% of your payroll. This would be put into a single risk pool, which would negotiate and pay all medical bills in the state of Colorado. So get rid of all those multiple payers, multiple rates, multiple negotiations and forms. Unfortunately, because of Tabor, the way the question read was, shall taxes be increased $25 billion annually? And as you might imagine, that did not get the warmest reception by the voters of Colorado. It also, in spite of the fact that the governance was not through state government, it was still called a governmental entity. And so the results were basically that we were creamed at the ballot. There was a 79% no vote, 21% yes. And people in politics, and people have said this was the goal of the opposition. They try to defeat you bad enough that it doesn't make sense to come back and try again. And so if we had gotten 40% or more, it would have been a bigger threat coming forward. It's pretty hard to come back from this number, although our current government is trying to help us, U.S. government, sorry. So people say, well, what do you think went wrong? And I think there are a number of things, some of which we could fix, some of which we can't. The first is that there is a lot of money in healthcare. Somebody asked about special interest, right? What I like to say is one man's cost is another man's profit. Dr. Adela mentioned freestanding emergency rooms. I don't know if you saw this week, there was a release about profits in the Colorado healthcare systems, and our Health One at hospitals like Skyridge and Swedish have a 40% profit margin. That means for every $100 they collect in medical bills at Swedish, $40 goes to stockholders. We had formidable opposition, and they all aligned. We had even actually within the Democrats, there were people who were concerned that this was too progressive, that it would work against Democrats getting elected in more moderate communities like Weld County and Greeley. So they worked against this. Americans for Prosperity, which is the Koch brothers, worked against us. And then a big group of statewide organizations that really was primarily businesses, because they did not want to have to pay the tax. They were concerned it would put a squash on business in the state of Colorado, worked against us, and we were significantly outraised. The anthem itself paid $1 million to defeat our ballot measure, no surprise. The ones that did surprise me were things like Kaiser, which is technically a not-for-profit organization. And then our health one wasn't surprised, but like Centura, which only has a 5 or 6% operating margin. So again, they also, even though they were not for profit, paid to oppose us. And we were outraised 10 to 1. The other thing is that, what I just told you about healthcare and multi-payer and single payer and how much is spent, you can't put that into a soundbite like the government's going to take over your healthcare, right? The government's going to tax you a lot of money. Those are really easy to sell. You can buy a cheap commercial. To get you to understand why a single payer system is better than a multi-payer system, we just never got a good soundbite that worked for selling this to people. During 2016, there was a lot of distrust for government, so much so that we elected as president a gentleman who had never been in government. And then because of the Affordable Care Act, I think almost every Republican ran on, I'm going to repeal the Affordable Care Act, and so it was a very unpopular topic. And so I think all of those contributed to the fact that we did not have a successful ballot initiative. We were also in that whole non-government thing labeled as the government running your health care, which was really interesting because what we had proposed was a 9-member elected board of directors. Open meetings to the public with financials being posted online, with independent financial audits, any premium increase in taxes being subject to a vote of the members of the state. And I don't think people realize that groups like Cigna, for example, have only 7 of, let me read the old lady glasses. 2 of 11 of their board members have a healthcare background. With Anthem, only 3 of 9 board members have a healthcare background. So really, the biggest difference is that our folks without a healthcare background would have had a vested interest and would have been accountable to the people. The other thing is that we had something put out by the nonpartisan Colorado Health Institute, which indicated that financially we were not going to be sustainable. Now, this is showing you over time where costs would be, where revenue would be under Colorado Care versus expenses and revenue under the current system. What I first want to point out is that the cost under Colorado Care would be $5.5 billion less than the same cost in the current system. So even though they were saying we weren't raising enough for health care, we would still be more on track than continuing with our current system. The second thing is that if you were to go through their calculations, the one thing they said was that the federal government would not give us access to all of our Medicaid funds. They cut Medicaid funding by a significant amount, and really there was no basis on which to do that. They were just estimating that. And in fact, if they had made the assumption that we did get all the Medicaid funds, we would have had an excess for the first 3 years and not needed to talk about increasing funds for about 4 or 5 years, which is very different than our current healthcare system. The other group, and this was actually through progressives that ended up working against us, were women's health advocates like NARAL. And what they said was, well, in Colorado we have a law that says you can't use state funds to pay for abortion, and so Colorado Care won't be able to pay for abortion. And we consider that pretty, it was potentially true. We disagreed whether it was true or not. But the bigger thing is that, the number one cause of abortion is people who don't have access to contraception. And we've shown in our state the dramatic decline in unintended pregnancies with full access to contraception. And so that, in my opinion, is sort of what happened with Colorado Care. I would say the biggest thing, though, was that 3.3% tax for an individual, 6.6% for a company sounds like a lot, but when you look at what has happened since then and even before then with what healthcare costs right now, it's not as much as you would think. And somebody had posed a hypothetical question of how would Colorado Care do at the ballot in 2017, now that we've had a year of watching them try to fix this at the federal level. So that's what I wanted to present today. Thank you. The one thing that Adela intimated but didn't really get to speak about very much is all of these efforts you see at repealing the Affordable Care Act right now are really the federal government trying to repeal Medicaid and Medicaid expansion. And so one of the things they continue to discuss is turning Medicaid into a block grant, where they say to the state, here's how much you get, no matter how much more you spend, you don't ever get any more money, and then putting the burden on the states. And that's when you see the people coming out and protesting, particularly people with disabilities, because we know that every year medical costs increase. And right now, Medicaid increases their spending proportionate to medical cost. So my premise is that if Medicaid spending stays the same, yes, this would still work. If they change Medicaid spending at the federal level, everyone across the country is in trouble, because so many of our sickest people rely on that for the most expensive medical care. So he asked, how would the proposal to take away the individual mandate affect Medicare? So the individual mandate actually mostly affects private health insurance. It does not affect Medicare as much. So the reason they save money with the individual mandate is, if you recall, if you're not getting your insurance through your employer and you go to the exchange will basically pay whatever your insurance is going to cost above 9.5% of your income. And so if the government no longer pays that because you're not buying insurance because you don't have a mandate, they're saving money, but you're not getting insurance, and the cost of that insurance goes up, so that those people who are sick and don't really have a choice, they have to buy insurance, their costs are going up. So what they're really trying to repeal with the individual mandate is their need to help you buy insurance, but that won't affect Medicare. She asked what can be done in public health to help control health care costs. And it's interesting because this is sort of the new era you hear a lot of discussion about. There's this slide I don't have here that I've used before that shows that if you look at what are the determinants of health, what determines if you have a healthy population, only about 10% of that is access to traditional medical care. 40% of that is behavioral factors, most of which is obesity and smoking. So if we could get everybody to not smoke and to exercise regularly and lose weight, we would control healthcare spending dramatically. Next to that would be about 30% genetic, which of course is harder to control, but they are looking at finding genetic interventions for diseases. And then about 20% environmental, and a lot of environmental ends up being related to your educational level and what kind of environment you can afford to live in. We know that people who are poor live in higher pollution areas, have higher asthma rates and hospitalizations. So those are what we call the social determinants of health, and you're seeing in Medicaid more discussion about how can you impact the social determinants of health, and that includes things like housing, having access to housing, having good nutritious meals, and interestingly, the healthiest people in our nation are the best educated, so some would argue that that includes universal preschool as well, to try and get people on a track to good education and better health behaviors. And then in terms of what's next with Colorado Care, personally, I wonder whether if we went for a model more like the French model, where we had regulated not-for-profit insurance, where the central authority, and I won't say that bad G word, help set what the prices are, and everybody had access to a basic plan, either buying it through their employer, through funding from the employer and employee, or through government funding, and then allowed on top of that private insurance for people who wanted to buy it. I think that might be more palatable, less foreign to the American people than going to complete renewal like a Colorado Care plan. But Medicaid is trying to enhance their payment to primary care providers and give them an additional payment every month to manage a person's care, because often if you can work with your primary doctor, you can avoid the need to go to an emergency room or to be hospitalized or to be re-hospitalized once you've gone. And so there's a lot of focus on what we call patient-centered medical homes, looking at the whole person, including mental health in that, because as you know, your mental health intervenes with your ability to manage your own health care, and focusing more on social determinants of health. And in terms of a different model, that's being discussed. The other thing that's being discussed is how do we start introducing some competition against private insurance that is not for profit and lower cost. And as Adela mentioned, the concept of allowing Medicaid buy-in has been brought up. The idea there, because of course, as a whole, I'm sure it would be poo-pooed on, would be could we offer it in our regions of our state that have the highest cost premiums right now, like in our mountain regions, or can we offer it in regions in our state that only have one private insurance on the marketplace right now? And then by doing this, build some trust that, yes, a government paid for system could work in some ways better than the traditional. And then I'll be doing a bill this year around this concept of reinsurance and premium reduction, where we sort of say as a state, okay, as long as you're paying 9.5% of your income, assuming you're not on Medicaid, toward health insurance, we as a state will find a different way to collect money to pay the difference so that it becomes truly affordable to people and not just for people below 400% of the poverty level. Yeah. So the issue with the individual mandate has been twofold. One is that it actually was set pretty low. And so for many people to pay a fine of $695 a year is much less than their cheapest health insurance would be. I have a 26-year-old healthy niece. Her cheapest health insurance is essentially $2,400 a year. And so if she's healthy, she's going to pay the $695 fine thinking she'll never need that insurance, right? But as you know, health is something that you can't take for granted. With respect to the environmental issue, you know, I think actually in Colorado that if those issues are put to a vote of the people, that the will is there, and that's why so much effort is put toward not putting it to the vote of the people, and I'm certain we would have an extremely well-financed campaign to defeat that. I worked for 23 years as a doctor at Denver Health doing primary care internal medicine. And people always say stories are best. And I literally had a woman who worked as a secretary, did not get health benefits, had diabetes, and basically never could control her diabetes because she couldn't afford her medical care, and got a common complication of diabetes, which is kidney failure, and then qualified for Medicare. And now we were paying $70,000 a year for her to be dialyzed instead of paying $10,000 a year for her to keep healthy. She quit working because 3 days a week of dialysis will make you feel pretty crappy. And long story short, by 66, she was dead from other complications of diabetes when she could have been alive and working potentially till she was 62 or 65 years of age. And so, you know, that story and the fact that if you're unfortunate enough to come to the emergency room having had a horrific stroke that leaves you paralyzed in half your body and leaves you needing to be in a nursing home, once you deplete your resources, the government will pay for you to live in a nursing home for the rest of your life. But we didn't pay for you to go see a doctor to see that you had high blood pressure and prevent that from happening. And so I was like, okay, why does this not compel you? But so I'm not sure.
Thank you very much.